Good morning, Charlie. Thank you for taking the opportunity to look at this video. What I'm going to do is talk to you about some of the ideas on why we're doing this particular protocol. I then explain to you a little bit about some of the success we've had in making this. You interns who are viewing this on the blog, this will be your introduction on how to use this particular protocol when you're trying to co-contract the contractibility between the superficial and deep layers. Charlie, I'd also like to introduce with you one of my interns. This is Brian Wiley. Brian Wiley is going to be in assistance with me today. First of all, let's explain a little bit about what I'm going to do with your machine. First of all, we all know that it's a decompressive event that's going to allow the spine to decompress. But I think it does much more than that, and the way we've been using it, it's been making a lot better application. I'm going to use Brian to demonstrate that, and then I'll use the model to kind of explain that in more detail. First of all, let's say Brian is the spinal cord, and this is the nerve root that goes down his leg. And let's say that Brian has a herniated disc that's got pressure on that nerve root. So we have a couple of opportunities. Depending upon where this is located, either tight in the foramina or more distal, we know that if we can take the pressure off this by decompression, we can facilitate a healing on the system. We know that because we can cause osmotic vascular infiltration, and we can get the place to heal. The problem is, how do we coordinate the difference between superficial muscle, which are the big erector spinae on his back, and the deep muscles in the back, which are called the multifidus. The multifidus muscles run between transverse processes. We know that there has to be a contractibility of co-contraction, or a governing apparatus that coordinates the contraction of your middle or your deep layer to your superficial layer. And we think that all goes through the facet. Now, the reason that your machine works so well for us is because this allows us the opportunity to put that person in decompression but take slack on the nerve root. Now, let me give you another example. Go back to Dr. Wiley. If Dr. Wiley is the herniation, and if I put him in traditional decompression, is I pull him down like this. What I do is I pull the nerve root tight over that decompression, and I increase that radicular symptoms. But if I can put the disc in decompression, which would be in here, and at the same time I could relax his arm and take the pressure off the nerve root, then I get the best of both worlds. So what we've been practicing on your machine to do is that if I have a herniation, I need to treat the herniation with decompression. But if I do, and I pull that nerve root over the top of that disc, I'm going to be in trouble. What we do is we're going to decompress the disc while we slack the nerve root. And then while we do that, we take all that inhibition out of the facet, and while we're doing that and slacking the nerve root, then we're going to rotate the facet and take it through flexion that's going to increase the angle at that area. And we do it in 30-degree sectors. So I'm going to go ahead and take a minute now and set Brian up, and then I'll show you what I'm going to do this, all right? All right, thank you, Charlie.
I always seem to catch you right at the perfect.
Let's put you out straight to begin with. Let's just put the demo down. We usually start to stretch out the IT bands. Great, Betty.
Right. Just a hair. I can live with it. Hey. Good, how are you? Hey. Okay, let's make sure we stay left enough to put half the table here.
Brian, could you get a hand dynamometer? I mean the goniometer out of my black bag, please. It's on the side there. Once we've got the person strapped to the machine, we'll give the control to the individual. And at that point, we'll instruct him that the green button goes down. He'll take pressure off his low back. So we want him to feel most of the pressure's gone and just a slight little pressure on the bottom of his buttock. At that point, I'm going to have my senior resident, Dr. McGochran, come in and goniometrically measure the hip-ankle angle. Dr. McGochran, come in. We make sure he's at close to 90 as we can. Once we get that degree at 90 degrees, then we're going to do a test and look at how much of our straight leg raise causes radicular symptoms. So in this case, we're going to bring him out to 90 here. and we'll bring it out to 90 here. You guys gonna walk her out front or the side, or?
Yeah, we're going out this way.
Okay. Once we get the machine set at 90 degrees, first we're going to do a test, and he can tolerate this well from a straight leg raise sign. Then what we're going to do is we're just going to torque his hips from side to side to try to stretch out any IT band that might be giving us infiltrations on both sides and causing muscle inhibition. So we go this side here, we go back to this side here. We also try to stretch out in this particular quadrant, the quadratus lumborum. So once Brian's got him at 90, just a tad more. Then what we do, we've tried that a couple of times. Now we're going to start the therapy. The first thing we'll do, we'll put his legs at 90, we'll put his knees at 90, and Brian will tell me when I have him exactly at 90 degrees. This is where we'll start. A lot of times if they have a herniated disc at this point, we're going to have a lot of symptoms. So what we do is, remember, we want to slack the nerve root. As we decompress the disc, we want to take that pressure and take that slack off it. So once we have him where he's comfortable, I'll tell the patient to drop the bottom of it out until he feels that he's totally being suspended. At that time, Brian will retighten the gap here. We'll gap him about 2 inches underneath until he's fully suspended. At this point, we do 10 reps right, 10 reps left at his first angle. Usually we try to put this at 90 degrees. It looks to me like Brian might have him a tad higher than that. Brian, you want to check those numbers again? And then I'm going to manipulate his spine right and left and do it in sequences of 10. Remember, we're trying to slack the nerve root and restore motion inside the facets, because that helps us control the co-contractibility between the superficial and deep layers. When you hurt your back or you injure your intervertebral disc, your facets are going to splint that deep layer. They're going to shut that down actually, and you're going to force all that reactive splinting to your superficial layer, and that's why you're bent over like a crab. So in that case here, we've got him at 90. I'm going to manipulate him right 10 times. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And then I'll take him to the other side. Put him at 10 here. 1, 2. Brian, get ready to move him up into the 30 degrees. 4, 5, 6, 7, 8, 9, 10. For the sake of clarity in this video, rather than take you through 10 of those, I'll just explain that and avoid Brian having to go through that. At that point, we take him up another 30 degrees. Now, we take it from 90, take him up another 30. Brian will document the angle, and we're also charting the pain. We would ask the patient, what do you feel at 90? 0 out of 10. Then we'd go up to another 30 degrees. You chart your pain there, and we're going to find that sector where the facet moves most freely with the least amount of pain. We feel that that's the area that we're going to start to coordinate contractibility between the superficial and deep layer. So once again, we do 10 here, 10 right, 10 left, and then once again, Brian will take him up another 30 degrees. Take it up again, another 30 degrees. Here we pick the leg up. Once we get it up to pretty high, we ask again the pain one more time. We make sure we have another 30 degrees. At this point, we have to be a little bit considerate about blood vascular compression on the popliteal artery. So by here, we realize that, and we take a little bit more, we go through our series, but we also are very conducive to watching the dorsalis pedis and looking for any vascular concerns. Once we get him up to 90, and we've cycled both sets for 3 different sectors now we're going to ask the patient to go ahead and contract. So he's going to contract and pull it this way, and then swing it back to the other way. So we're going to have him contract here. You can either have him swing back and forth, or you can have him just do 10 types this side. We would like it to be rather quick, not slow, because quick we want to engage the type 2 fiber and the fast twitch fiber that helps control the mechanoreceptors on the facet plane. So Brian, go ahead and go my way quick. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Try to get a little bit more of a swing now, Brian. Let's try 1, 2, there we go. 4, 5, 6, 7, 8, 9, stop. We go the other side back and forth. And then what we would do is drop him down another 30 degrees and repeat the procedure again. Brian again would document that. Once again, Brian, to my side, till you touch. Go 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. We're not looking for pain there, we're just looking for his ability to contract. Go again. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. What you're going to see is when we move him passively, your range will be different than when we make him contract it quickly. He can contract it slowly. Brian, pull it all the way to here if you can. Most people will be able to do that. Back to the other side, they'll be able to pull. The problems we're getting into is we want him to do that quickly so that we can get that spine and that middle layer of stability, or that deep layer of stability, to contract quickly so we can take advantage of the type 2 fibers. Once again, we go down to the lowest place again. We go down to about 90 degrees. At that point, we go through this one last time. We have the patient bring the buttock up. Go ahead and hit the red thing till back until he feels his compression. We notice that when he starts to do his exercise routine, now we take that up so he just slightly feels it. We stop. We usually sometimes go back up it again. We're very sensitive in taking off the decompression. So, once again, we got just light pressure on his buttock. Maybe I'll stretch him here. Maybe I'll stretch him here a couple of times, 5 or 6 reps. Have him add another couple of pounds to pressure, and have him just sit there for a minute. Do another couple of sets here passively, another set passively here. Add another little bit of compression. I can tell the resistance on his buttock. Now he's getting a little bit of firm pressure there. That's probably close to about 50% of his body weight. A little bit more. That's good, Brian. He's right there. I'm getting pretty good compression. You can hear the thing slide underneath his buttock. And then a little bit more, Brian, and you feel like all your weight's on there. About there, relax. You'll see the difference that he doesn't spin as well, and I know he's under load. At that point, I'm just going to let him sit there for a minute. I'm going to let his legs come off. Put his feet up on top of the pedestal, if you would. Drop his foot here. Drop his foot here so he has blood vascular supply. And then I'm going to bring his knee up to his chest again. 1001, 1002. Here again. 1001, 1002. Have him activate his core. Bring it up again. 1001, 1002. Now we're going to prepare him to stand up. At that point, we'll release the pressure here. Release pressure here. And release pressure here. And then at that point, activate his core again. Pull his knee to his chest. Pull both hands. Back to here. Pull up. Both legs again. One more time. Right side. Left side. And then we're going to have him stand on my command. Does that feel like that's too uncomfortable? Would you like me to drop that down?
No, it's fine.
A lot of times it's too uncomfortable. If the angle's at 90, I don't want to have to take down again. So what I'll do is I will kick the stool out, use the control, and drop him down until I see 90 on the floor. 1, 2, 3. Go ahead and stand. I use it kind of a seated assist so that I don't drop him on here in case his legs or has radicular pain. And then he steps down again and jars himself. So basically, in recapping what we've done, is we take the spine through 30-degree sectors of flexion with decompression, and we spin the facets during those different 30-degree sectors in order to coordinate the co-contractibility between the superficial and deep layer. And we do that after we do it passively by having the patient contract quickly to control that range to try to establish that type 2 fiber. I hope this has been beneficial to you. Obviously, it's a progress in work. We'll be sure to update you. Once again, we thank you for your product, and we hope to see you soon. Thanks, Charlie.